Hello, my name is Linda Trentham. I am a psychiatric mental health nurse practitioner student at Frontier Nursing University, and this is my presentation of my formal paper assignment. For my paper, I chose the topic of borderline personality disorders, its risk factors, treatment options in adults. To start, I'll discuss exactly what is borderline personality disorder, and this will be brief. Um, There are many variations of this mental illness, but particularly this diagnosis is an umbrella term, if you will, that manifests in the patients as a world viewed in extremes. These extremes can be viewed as a roller coaster of thoughts, beliefs, and behaviors, which can cause a multitude of reactions to their reality. These symptoms typically manifest in early adulthood. This presentation will discuss risk factors such as genetic predisposition and environmental influences, and their treatment options of BPD, more specifically pharmacological, and psychotherapy. Genetic predisposition. There were inconclusive findings relating to genetic predisposition of BPD. However, a few key points were made in a few aspects. Maternal psychopathology, or the mother's own mental illness history, had a significant correlation in the data. I found interesting that the father's substance use, not necessarily his abuse or his use in excess, was noted to be a predictor of BPD in a child. Another key point was that a family history of psychiatric hospitalization showed an increase in BPD symptoms in a child later on in life. This information then raises the question, however, is it the underlying genetic code, or is it the presentation of the parents or caregiver's own mental illness that can affect a child in such a way that there is an increase in BPD in later years? This brings us to environmental influences and their effect on the adolescent. The data that was found showed that the direct environment around a child played a large part in the later diagnosis of BPD. The caregiver, not just the parents, who had poor communication skills or inconsistent parenting styles, could negatively affect the child's outcome. Additionally, a consistent link in the data was trauma and stress during childhood. This is where that line between DNA and parental mental illness symptoms becomes a little fuzzy. For instance, a mother or father with uncontrolled bipolar disorder does not provide as stable of a home as a parent without bipolar disorder. There are two factors to account for, and there are still studies being conducted in order to determine which factor is the most correlation. What I did find interesting in this particular article that I found was that there were structural changes in the brain after such trauma. This can negatively affect the medications that we're using to try to treat symptoms of BPD. Here's a wow factor. There are currently no FDA approved medications for BPD. With all of modern science, there is yet to be a magic pill for this illness. However, there are many BPD patients with two or even three medications on board to treat an associated symptoms like mania, depression, anxiety, and others. Remember what was said previously. Some of the regions of the brain have been structurally altered, which can make these common go to medications useless or even detrimental to the well being of the client. So, if there are no medications specifically for the patient with BPD, and the medications being used may cause harm, what's the clinician to do? One of the most important objectives in treating BPD is first the clinician and the patient relationship. These patients have become dependent on the quick fix of a pill, and if that clinician sweeps in on day two and strips away their security blanket, that patient's more than likely not coming back. But if a clinician takes time with these patients and discusses treatment options and goals on both sides of the table, educates that patient, and this may take several visits, regarding the use of medications prior to discontinuing them, there is hope. These patients are complex, and their current medications may alter their true presentation. So it is important that the clinician safely taper the current medications down and start from scratch, if you will. One key point to mention is the BPD patient is at a higher risk for self harming behaviors. With that being said, benzodiazepines are strongly discouraged. If a crisis happens to arise, it is important for the patient and the clinician to discuss altering their environmental triggers rather than add a very addictive drug on board to an already unstable patient. Moving on to therapy. Dialectical behavior therapy, or DBT, was designed specifically for the patient with BPD. Its focus is on the mental stability and recovery of the patient. The forefront, as we discussed earlier, is the trusting relationship between the patient and the clinician. This is key for the continuation of treatment and the use of skills learned by the patient. The therapy teaches the patient how to interpret and how to manage their emotions and their environment around them. The toast burning in the toaster is not the end of the world for you or I, but it is a huge deal to the patient with BPD, where there is no gray area of emotion. The therapy's objective is to help the patient better understand and interpret those particular events and learn to cope with them using coping skills that are unique to them. The overall ultimate goal of the therapy is a decrease in self harming behaviors as a result of varying environmental causes. Another form of therapy focused on the patient with BPD is cognitive behavior therapy. It's similar to the previous one in the sense that the goals are the same, but it takes a different path to get there. Its goals is to help the patient identify the misconceptions of their reality, or the burnt toast, and teach them self awareness about their reactions and feelings. This method also aids the patient in reducing instances of erratic behaviors and outbursts. In conclusion, we have had a very brief overview of BPD, its causes, and its treatments. The BPD patient is typically impulsive and emotion driven due to their inability to effectively interpret their environment. The causes, although they have been linked to genetic predispositions, have more often been related to environmental factors such as trauma and stress. BPD patients are typically overmedicated due to their complex presentation, which can be dangerous due to their self harming tendencies. Psychotherapy has been an effective option for most BPD patients, but that's only if the patient will trust the clinician. In a world where there are many inconsistencies from moment to moment, this mental illness can be detrimental to so many, and it is difficult to diagnose and to treat. But it is up to the clinicians to gain as much knowledge as possible to keep these patients safe. Thank you.